Can you do your thing?
Yeah, I don't think they have to.
You don't think they have to?
No.
Hello, ladies and gentlemen. My name is Manju Patel, and I'm going to introduce speakers, which is Kyle Whitfield and Martin Labrie from Alberta, Canada. And they're going to talk to us about community capacity development for enhanced hospice palliative care.
Thank you.
Thank you. That was a very hard act to follow from Dr. Bowden's presentation. But it's a pleasure to be here, and it's really a pleasure to be on the same stage with my colleague Martin Labrie. Just to give you a little bit of history, we're both from the same province in Canada, in Alberta. And Martin and I were both working with different communities. In Alberta, myself as a researcher, working with a community as they were leading their own process in hospice, in trying to determine how to enhance their care. Martin was working with another community, also supporting them and facilitating and mentoring their process. And so it's been really wonderful for both of us to come together to learn from each other. And what we hope to present today is some of the things that we're learning together as we begin to embark on a study in the near future. I'll just start at the beginning and say that I'm a planner. And so I'm coming at this from a community planning perspective in terms of how do we plan for and use planning approaches that help to foster good care in our communities. I don't know how to make it go to the next slide. Nobody taught me that part.
There's a one there.
So generally, we've got some guiding questions that we're using. We're going to give you a little bit of context about the history and evolution of hospice palliative care in Canada, speak a little bit more specifically about Alberta, talk a little bit about what the kinds of things that we've been thinking about with regards to community development and what we are thinking about with regards to a community capacity building framework. We've got a little bit of wondering and critique about public health and community development and how those work together or maybe don't work together. And then end with some provoking questions. So I hope that works for us. So the guiding questions that we're using to take us through this presentation really are about the role that communities play in addressing hospice palliative care of its members. And when somebody is confronted with a life-limiting illness, what is the role of the community in responding to and in walking along with that person throughout the journey? And then secondly, what are the capacities that are required in that community to sustain them through these processes as they carry on? So more specifically, we've been thinking about what kind of expertise and what kind of infrastructure, or what kind of expertise from an infrastructure perspective, from a personal capacity perspective, and also from a policy perspective. From the research and the work that both Martin and I have done, our next question is, where there is community engagement already occurring and having already occurred in a community over a significant period of time, over a 4 or 5 year process, what's the value of that? And what's the value of that for the people living in that community? What's the value and the impact of that for service providers and but mostly for that community? So now I'm going to turn this over to Martin, who's going to talk about palliative care, Alberta, and then I'll come back to the podium. Clicker.
Thank you very much. So really what I want to do is just give you a bit of a context of where we are, where we've been, and how we've gotten to where we are in this point of research, and really the specific kind of communities we're talking about in the Alberta setting. So this is me in 1983. This is what it was like for me. I was fresh, a year into my practice, trained in my residency in family medicine with an interest in palliative care. And at that time, it was a counterculture movement. And many of you who were there maybe at that time remember that it really was about convincing people that there's something else other than to the medical management of illness, and that it's not just about medicine alone, it's about addressing the suffering that people face with life-limiting illness. So in Alberta, it started off very much the same as everywhere else. Palliative care emerged in the late 70s primarily as an alternative to medical intervention for management of palliative care. And a lot of what I'm going to say here now is actually Denise Marshall kind of stole my thunder, because it reflects what's happened in the rest of the country as well. So in the late 90s, it was groups identifying themselves. In our own community, it was around cancer care and people within cancer care identifying the need for being able to address suffering. By the late 1980s, the advances in palliative medicine and palliative care led to the professionalization of palliative care. It was healthcare professionals who were looked at by community leaders to be able to not only promote, but to provide care. And we jumped in with wild abandon, so that by the mid-1990s, it was well established that care providers were starting. Our first residential hospice facility in Alberta was opened in 1992, and it was 2 rooms on the bottom floor of a senior's home. It was not even assisted supported living type of an environment, but it was on the main floor. There was 3 rooms, and then the secretary's office. The clinical nurse specialist in palliative care who established it had the secretary doing things like changing catheters and stuff like that, and it was just right off the side of our desk sort of thing. And that was the initial hospice that we developed. So there was some success in getting going, and then in the mid-90s, healthcare was regionalized in the province of Alberta, and as you saw from Dr. Marshall's presentation, Alberta is a large place with very few people. There's 4 million people in the entire province. There's 2 large cities and then a large number of rural, agricultural and industrial communities, mostly around the oil industry. So very widely dispersed population, although most of them are urban-based, as most of the urban settings are quite small. So what happened is that by the time that regionalization came along, we've been pretty successful in starting up some small initiatives to be able to provide residential hospice care. There had been the development of a dedicated home care program in my city, not in Edmonton, which is the other large city, but in my city in Calgary, Calgary Health Services have developed a dedicated palliative home care service. And we were all linked. We were a small, relatively small community. We knew each other and we related well together. But then what happened is that the burden of these places were established through private donation, and the operating funds were through private donation. And many of you know what that's like. It's like waking up scared in the middle of the night that you're not going to meet your payroll. So it was a huge burden for everybody. And there was a lot of pressure for this nascent regionalized healthcare service. At the time, we were I think 17, we went to 9 regions, and subsequently now we're 1. Here we're going back to 11. I'm not sure about that because we just had an election, but it's been very complicated in how the structures develop. But over time, and particularly in certain parts of the province, these community-based hospice and palliative care organizations have become integrated into the service provision of the health system. So we've become very highly medicalized in our palliative care service delivery. In all of our acute care sites, there are palliative consult services. I work in several acute care sites in Calgary. It's the same thing in Edmonton. So tertiary level palliative consults are available, not just in those settings, but also in the home care setting. It's become very specialized, and even the physicians in our communities have identified palliative care as something that is provided through specialist services. And so it's been very much alienated from our society. So we've been very successful in trying to do those things that I was doing in 1984 to try to be able to get palliative care integrated into healthcare, but it's been at the expense of what's happened in the communities. Now where we are is that the residential hospices are all contracted. If they're run by not-for-profits, they're contracted, and there's a few that are corporation-run that are contracted to the health service to provide residential hospice care. The home care is run through community care coordinators that are RNs that really just are direct services like private, for-profit nursing support, licensed practical nursing support, or whatever is needed, companion care in those settings. And it's very much going through and operationalized in a very conservative, very corporate structured facility. So it's become very much separated from that community movement that we've had. And the standards are set by the people that pay the bills. So the clinical standards, but also the other standards are set by the community. So it tries to be a one-size-fits-all for the entire province, despite the diversity of the province. So where we are in right now is we have one regionalized health authority for the province. They set the standards. We have palliative care resources integrated with healthcare services throughout the province. You have to be able to access the healthcare service, which is a challenge for people who are marginalized, people from ethnic communities, for example. Aboriginal communities have very great difficulty accessing healthcare services, so palliative care is very difficult for them as well. And as I said, we have 2 large urban areas, some smaller cities, and very large number of small towns that might range from 500 to maybe 5,000 or 10,000 people that have unique social, economic, geographic, and healthcare issues that are not addressed by this. So where we are is that palliative end-of-life care is now perceived to be an expert. If a good death is when somebody can die, preferably in their home with the support of a home care team, and their pain and symptoms are managed, they get to die where they want to. That's considered a good death. It doesn't look at any of the collateral damage that occurs with burnout of care providers and the burning of cash and resources that families have to go through in order to be able to do this, and the moral distress of the community where we see people suffer and we're not able to address it. So while deaths outside of hospitals have fallen in our area, in both, especially the large cities, the number of people that die at home has not risen at all. And we are now just moving people into residential hospice facilities and long-term care facilities, which is an improvement, but it does not do anything to help and bring people back into the community, or it's very limited, especially when you're going into a hospice run by Intercare Corporation, which is as heartless as it sounds, quite frankly. So death has become more obscured, and community knowledge has been about end-of-life care has decreased as well. So access to end-of-life care depends on access to the healthcare system, and the decisions regarding the standards of services are provided through a central authority that cannot respond to local needs. So this is the environment now, where, as Kyle was saying, we've become involved. I was involved as a mentor for a group that was of community leaders in a center that has been once, not too long ago, a rural center that has now evolved into a bedroom community for Calgary of about 60,000 people. Strong on community, it says community on their sign driving into the city, but very limited knowledge. They just wanted to build a residential hospice, a bricks and mortar hospice where people could go and stay. And they would be looking at being drawn into this Alberta Health Services. So my response to them was, why don't we look at helping people not just stay in their homes, but as part of the community, increase and improve the community's capacity and all of the things that we all know about today. And they got on board. We got to a certain part where they developed their governance, the organizational structure, and then it stalled. And quite frankly, now they've evolved back to looking at building a residential hospice. And when I ask them why, they say, well, every time we talk about developing community capacity, it just drains the energy out of it. So what we became interested in is looking at what these organically developing community groups would need by way of infrastructure and policy in order to be able to get beyond that stage and help to develop that capacity, because that's where they hit the wall, is in trying to get these things going. Volunteer coordinators, executive director, or somebody who has knowledge about developing this community capacity and can help them out. So our research is intended to look at what policy we need to be able to develop and how to be able to help the decision makers to help these communities to get beyond that, and then to measure the value that that brings to communities by way of the social capital that's gained and improvements. And we'll have to prove that there's fewer emergency room visits and all of those things, but we also want to be able to measure that social capital that is accrued to a community when they can get beyond that moral distress of watching somebody suffer. This is where we are right now, and I think Kyle's going to take over from here. Oh, so this is me now, trying to get out.
Looks just like him.
My hair's shorter, but I'm still trying to get out. So this is where, just to set the context now, Kyle's going to come back and talk to you about where we're going with our study.
Thank you.
So in the study that I was involved in a community that's about an hour and a half or so in between the two large cities in Alberta, the question that I asked was, as you as a community are moving through this process of trying to find ways to meet your end-of-life care needs, what's helping you and what's hindering you? And this is a group of citizens who started out as 3 people, and they became 5, and then they became, then over a few years became a hospice society, and now fundraise, have their own governance system, etc. But again, as Martin referred to, there is an immediate desire for communities to automatically say a residential hospice is a good place to foster a good death, and so we want to have one too. They have one, and there's one there, and there's one there, and we deserve to have one too. And so we're not giving the impression that we're against the role of residential hospice care. However, not every rural community and not every community necessarily needs a residential hospice care facility. And so there are lots of other ways to provide hospice care. And so we're interested in looking at that. So in summary, the facilitators that the particular community talked to me about were that the things that helped them the most as they moved through the process of addressing their hospice care needs were, number one, it generated a lot of awareness within their community. The term hospice, people would say, oh, you mean hospitals? What do we want to have hospitals here? So even the language was elevated. They described feeling like that they as a community were put on the map people came to know about this community because they themselves started investigating in other communities in the province. What have you done? What have you done? What can we do that is similar to what you've done? And so a lot of sharing of knowledge throughout the province, which was a lot of work for these citizens as volunteers. And they also acknowledged that people in their communities were very, very willing and ready to offer them large sums of money, quite frankly, and even buildings to have a residential hospice. And so this propelled them forward. Okay, that 5-minute rule just came on. Scary 5 minutes. And so some of the barriers were the lack of provincial guidelines, but most importantly, they identified the significant workload that they totally did not anticipate having on their shoulders. And I'm just going to skip through some slides and reiterate that what we're finding in both the literature and that what is becoming clear to us as we're aware of, I can think of about 9 or 10 communities in Alberta, 2 of whom have agreed to work with us on a study to look at what are the characteristics and what are the conditions that are necessary to foster and build in the community in order to meet good care needs. So community versus service needs, issues around infrastructure, whether that be volunteer support, whether that be the role of organizations. I really love the word on Dr. Hoda's slide, the role of retail organizations in playing a role in care. And then how does that link to policy? So I'm going to skip that slide and move to the questions that are provoking us as we move forward are really about infrastructure and policy, and asking the question about where there is a community-led and a community organic process already occurring, is that a value to good hospice care? And what are the impacts of that at an individual level, at a service provision level, at a volunteer support level, and then at a system level? I don't know the answers to those questions, but it seems to me to be a natural next phase in the research process for us. And so I use case study approaches, and so we're going to use these, work with these 2 communities who have agreed to work with us. But I think what is really cool is the last slide, which Martin found right here in Bristol.
Oh, in Bath. It was in Bath.
Oh, in Bath. As he was walking down the street, change priorities ahead. So we are in a constant state of movement, and I'm going to just give the last word to
Questions?
Okay, yeah. Yes.
I'm just really interested, thank you. It's really interesting to hear because you're obviously in such a rural area in the area where you work. You think the communities would be more engaged and more proactive sort of generally with things and come on board with what you do.
Well, the issue is around medicalization of the palliative care, and it's in the health system, and our health system is very centralized. Much of the secondary, all of the tertiary levels, care is in the city.
In urban
and we will fly people from from remote parts of our province into the cities to access things like cancer care, for example. At least for their initial consultations, they may be able to get cancer treatment in smaller centers, but it's all there. So these communities have learned to be able to be dependent on these kind of structures for all aspects, and that this is going to be integrated into the healthcare system. The healthcare system will provide palliative care because it's mandated for the health service. So we have to unlearn that. We have to get back to all of the things that are in the social charter that Professor Killier is putting out are there, and we have to be able to help people to understand it. But what we don't know is how to be able to effectively do that, and even to convince the decision makers that are coming in. As Dr. Marshall indicated, we're now socialists. We're not socialists, trust me, it's not. It's just less conservative, but they call themselves New Democratic. But it hopefully will allow us to be much more progressive and allow the decision makers to be able to start hearing these messages. But we have to show them how.
But I think their ruralness is a condition of their need to work independently together as a community in order to respond to a need that they know that they can't just keep relying on having to go to long-term urban centers. So I think ruralness, yes, does play a role. And obviously rural and rural remote have different characteristics also.
Please go ahead.
Just prompted by the last question that what is discussed tonight about the community involvement. And I'd just like to mention some case studies in northern Sweden. And what they did in northern Sweden in quite small rural communities is they had, I guess you might do, London hospices on people's homes, I guess, but they were quite small ones. But they incorporated into these places services that the community couldn't really support otherwise. So there might be a community that couldn't really support having a hairdresser, but because the salon was paid for within the hospice, that meant that the hairdresser didn't have to set up a salon.
Interesting. So,
and it meant that the community kept coming in and out of the hospice as just part of the village.
Well, those are important things. What we're talking about is local knowledge, right? And what works for that community. And so it was specific.
efficient use of resources.
So,
Right.
Okay, one last question.
So what is already there? Work with what's there is really the motto. Thank you.
Do you think, I mean, hospices are mostly funded by, as you were saying, generous people, fundraising or giving bequests and things like that?
In
And there
Alberta.
is a tension because most people will give money to a building, a residential building, and fundraisers having the building supports that. As we try to move towards a hospice without walls model, and we've reduced our hospices, reduced some of the inpatient beds to invest in more community, our community are saying, oh, that's terrible, you're shutting beds,
You're taking away services.
They're taking away something, and as a consequence of that, giving less money. So it's really, how do we, and I agree with you, the challenge is, how do we move people from that reliance on that inpatient to more community, because they perceive it that we're taking it away.
and the community has to own it. And we have to be able to help from the perspective of the infrastructure, the policy that they need to be able to get beyond just awareness, like having runs and all of those things, or even having, just being able to have people talk about advancing illness, end of life, and dementia. It's really impressive. Japan, we can talk about dementia in Japan. So, being able to do that is vital, but how do we actually help those communities develop that next step? We don't know yet. And that's why we'd like to focus on these, we'd like to focus our research.
And
There's a real tension in the hospital.
absolutely.
That's where
Well,
I
people
think
like to see tangible change, right? Just a comment that Martin often makes is that service providers need to be seen as community first, and then service providers. They don't need to be members of the community, but they are part of the community and they're part of the community capacities that are there. They're not, they don't, it's not serving us well for them to continue to be outside expert service providers, which is an add-on.
Thank you very much.
Thank you.
Thank you, Kyle. It sounds like you've got a very interesting challenge on your hands.
In 2 years in Canada, we'll be able to share the results with you, maybe.
Right. I'd like to introduce our next speaker, which is Rachel Zammitt from Cheshire, Whitfield, Diamond.
Okay. Hello everyone. As Julia said, my name is Rachel Zammitt and I am the Head of Public Health and Wellbeing for the End of Life Partnership in Cheshire. So I'm hoping that you've found the conference so far informative, but hopefully really enjoyable and inspiring as well. And hopefully we can add to that as well as part of this session. So in my presentation today, I'm really going to focus on providing an overview of the work of the End of Life Partnership, or the ERP, and cover hopefully the following questions. So 3 so what questions. So what is the End of Life Partnership? So how are we working with our partners and our communities? And so what does this mean for individuals, families and communities in Cheshire? Well, actually, the middle one is a so-how question, but I'm sure you'll forgive me on that one. What I thought I'd do is I'd actually like to begin by just showing you a very short musical montage to try really and set the scene about the work that we do at the End of Life Partnership, and hopefully then I can build upon that for the rest of the presentation. So please keep your fingers crossed that this technology works, because we know what technology's like, but here we go. Might not be working. Do you think we can fix this, Mr. Technology Man in the corner? Okay, while we're working on that, can you give me a thumbs up when we think we've got that going? Basically what the montage, hopefully we'll get it back, what the montage was trying to show is that we're a charitable collaborative, which means that we are a charity and an organisation in our own right, but we also work with a whole host of stakeholders from across the public, private and third sectors, and we also work to engage with individuals, families and communities. I don't know if I'm just, I can hear the music playing, I don't know if that's just delirium on the stage because the technology's going on. I'll continue and wait for the Mr. Technology Man in the corner. So we have the aim of working with our partners. Partnership is the very essence of what we do. With our strapline to transform end-of-life experience and care, and that's a very deliberate strapline because we are not just about end-of-life and end-of-life care, we are about a whole life course and how we can help to transform that life journey as well as death, which is part of life. So as I said, we're a charity and organisation in our own right. I'm just going to carry on clicking because I don't think I'm going to get it our way. It's not clicking. This is your worst nightmare for a presentation, really. Just stop clicking. Stop clicking. No, yes. Oh, it's working. It is, but it's not playing the music, so hopefully this gets in. It might get a little bit boring for people just to watch images.
Start singing.
Yeah, if we've got any volunteers that would like to do a bit of Heather Small, that would be great. We scroll down. Carry on, so you'll see another end of life partnership logo, quite a lot of slides. Yeah, okay, this one. Okay, so you didn't benefit from that, ladies and gentlemen, I'm really sorry about that. So, we work with our partners to try and transform end of life experience and care. And as I've said, we're a charity organisation in our own right, and we have a core team that consists of 4 dedicated departments. So that includes education and practice development. So that team has a focus on educating and training health and social care staff, and also the delivery of BSc and MSc academic modules. Our service development team, which also includes a dementia and a life practice development team, and they really have a focus of working with clinicians to enable and to facilitate excellent end-of-life care. Our public health and wellbeing team, on which my team have a focus of working with the public and the wider public health workforce to look how we can support people to engage in future life planning activity and also to support each other throughout the life course. And importantly, we've also added to our organisation a research, evaluation and technology department. And again, the focus of this department is evaluating the work of the core ERP team, but also working with our partners to add to our knowledge base. And of course, we have a business support team to help us with all those functions. As I said earlier, we're a charitable collaborative, so that means basically in addition to having a board of trustees, we also have what we're calling a strategic partnership executive. And that consists of all our key local stakeholders to steer, oversee and monitor the work that we do. So our key stakeholders are on the screen there. That includes our 3 local hospices, our 4 CCGs, our 2 local authorities, our 3 hospital trusts, University of Chester is our academic partners. We're aligned to our Cheshire and Merseyside Sheep Clinical Networks, and Care Trusts for All and Macmillan as our voluntary partners. And by steering, overseeing and monitoring the work that we do, I mean by that the work that we all do. So not just the organisational core team of the ERP, but all of the stakeholders within the partnership. So we work as an ERP to meet national objectives and to deliver on local priorities with our stakeholders, and that includes patients and the public. And our work is further strengthened by a dedicated Cheshire Living More Dynamo partnership with a purpose that works to enable the community voices to be heard. So membership of that partnership includes a whole host of people, so a variety of health and social care organisations, housing organisations, local businesses, Cheshire Police, Cheshire Fire and Rescue, church groups, faith groups, various community groups and organisations. So it really is opening this as wide as possible and recognising that ageing, death, dying, loss and life aren't just about, it's not just confined to the health and social care arena, it is about how we engage everybody within this process. This is a beautiful image, which we really like to use just to show how, as the ERP, we're really committed to working with our partners, with our clinicians, but with our communities across the whole life course. So at the tip of the iceberg, how do we make sure that we're achieving excellent end-of-life care for individuals and supporting families, but also the work that we need to do upstream. So how do we motivate and support individuals and communities to consider, to plan, and to communicate their wishes for what they want now, for what they want when they get older, and for what they want at the end of life. And how do we help them to do this throughout the life course? And of course, we need the continued support of our partners, of our clinicians, and of our communities to do that. So in Cheshire, we are in quite a unique position that we were one of the first areas in the country to have a dedicated public health and wellbeing programme. And we're proud to have established that and the successes that have been realised so far with the programme. And I think it's really important to know that the programme it's not just simply about raising awareness, it is about changing behaviour. And how do we motivate and support a change in knowledge, attitude and behaviour to improve individuals, families and community wellbeing? So through the Cheshire and Modern Partnership, which is our public-facing brand of the End of Life Partnership, we work to engage with the public and anybody who works with the public, so that we can enable, inspire and empower people to think about, to talk about and to take action in relation to their lives, in relation to age, in relation to death and in relation to loss. So we've heard through the conference already that from a health and wellbeing perspective, ageing, disability, illness, caring responsibility, they all impact on our health and wellbeing. And that's a significant impact as well, whether it's in economic terms or whether it's a social impact of that. And it's the fact that hopefully, we'll all continue to get older, but the one thing that we do know is that we all will die. And so as a public health issue, death has 100% prevalence, and that is never going to change. That's something we're never going to be able to reduce. But what we can do is help to improve people's health and well-being throughout life, throughout age, and have a good death as possible, and then support those that are bereaved and are left behind. And it's also about how do we help to support people to engage in future life planning throughout life as a natural and normal process. And the work that we do is really looking at making this a health and wellbeing issue. So just as we look at our lifestyle in terms of diet, alcohol, exercise, whether we're wearing factor 20 sunscreen, it's actually getting people to see that planning for the future, planning for now, planning for the future, planning for the death is a health and wellbeing issue that they should be taking action on and incorporating into their lives. And I work with communities and listeners communities at the very heart and essence of ELP. So this concept model I'm showing on the screen now. And anybody who's seen me present this before, you'll probably know my required response for this slide, because it took a long time to get those circles to move. So I do like a little bit of a woo! and since my musical montage didn't work, if you could just indulge me a little bit of that.
Oh, wow.
Oh, thank you. Made me feel so much better. Thank you. So the very central tenet of our work is living well. And that is where all our work is focused on and communicated to our partners and our public. Because how we live affects how we age, how we grieve and how we die, and then how we die impacts those that we love and we leave behind, and how they live, how they age, how they grieve, how they die. And so the cycle continues, and that's an ongoing cycle. So as the End of Life Partnership, we work to fly the flag for Cheshire and for our work on a range of local, national and international platforms. And we work with our partners and our public in a variety of different ways. So some of the images that are on the screen there now, working with, throughout our public health and wellbeing work, examples include consultation events, delivery of public skills workshops and talks, workshops to capture and record memories and significant life events, exploring ways with individual groups of people as to how to record their wishes and hopes for the future, will writing workshops, which include our local champions from solicitors and financial advisors, and our training courses for anybody who works with the public, paid or unpaid. And that is, it's really getting into that concept that if anybody who has an interaction with the community or with the public has a role to play in helping to make change and help people to change their thoughts, actions and behaviour around aging, death, dying and loss. And it's also around bespoke resource development. And some of the images you saw on the screen there is just trying to get a flavour of the diverse groups that we work with. So from older people's luncheon clubs to mums and tots groups to students at the university, and really spending the time to see how we can tailor our messages into a language that makes sense to them and will really enable and inspire them, as we spoke about earlier, to take action. And basically what I'm trying to say is we will work with our partners and our communities in a way that is engaging and meaningful to them, because this is the only way that we'll be able to get sustainable change and to really make an impact. So an example of how we've worked across all departments within the NWI partnership and with all our stakeholders is the work that we've done together on developing a new care plan for end of life. And again, this is one of our, I suppose, significant achievements, or significant milestone that's been reached as a partnership collaborative. So in response to the national review of the living care pathway, we incorporated through development with local stakeholders a care plan and education strategy to ensure effective rollout, public consultation and work to measure impact. So the leadership lines for the care of dying people, which many of you will know, is the National Coalition in England that was set up to work on the recommendations outlined in the independent review of the LCP, which was more care, less pathway. The leadership outlined 5 priorities in their response, and the document is called One Chance to Get It Right. And so for us, we knew we needed to respond to this, and it was essential that we adopted a partnership approach to develop a local plan to achieve those things that are written on the screen there. So how do we make sure we facilitate a timely and whole system response to the national recommendations? How do we make sure we maximise the potential of collective public and professional experience and expertise? To advocate for equitable approach across the locality, foster shared responsibility, to ensure transparency, and to promote an evidence-based approach to local care delivered during the final days and hours of a person's life. So what did we do? So again, working together with our partners and our communities, we developed a cross-departmental approach within the organisation. So the service development team took on the project leadership of this, facilitated group meetings, developed documents, navigated governance frameworks, and looked at the audits and data collection. The education and practice development team within the organisation looked at the development of educational materials to support the process, developed a comprehensive training strategy that met the needs, and also looked at the gap analysis of what was and wasn't already in existence in terms of training. Our research and evaluation team designed and analysed surveys for consultation events, supported with audit, and analysed audit. And in terms of our public health and wellbeing role for my team, it was really using our networks, using our relationships to facilitate engagement with the public. And again, to do that in a way that would be in a language that the public could relate to and could understand, and supported public presentations and question and answer sessions by the service development team. As the EOP, we are also, we've also been identified by Public Health England and NCPC, National Council for Palliative Care, as one of 8 pathfinders or pioneers for the Dying Community Charter. And this quote on the screen now is lifted from the Dying Community Charter, and it encapsulates what we know, we've heard in the conference. Dying and death don't happen in isolation from the rest of life. And for us, becoming a pathfinder of the Charter wasn't any different for us, because the Charter really encompasses the bread and butter of our work. And so for us, the approach was nothing new. It didn't mean the beginning of a new project or a new piece of work, because we're quite fortunate to have well-established programmes of work and well-established partnership approaches to supporting people in Cheshire to live, age, grieve and die well. And so for us, it was just an opportunity to galvanise momentum and show our desire to build on our existing work today. So, we want to work with people in Cheshire, regardless of their age, their health status, their ethnicity, and it's looking at, again, how we can make relationships with those groups, whether it's young people, old people, LD groups, LGBT groups, whoever it is, how we can build those relationships and how we can get them excited and inspire them to look at what they want now in life, what they want as they get older, what they want as a death, and what they want to do post-death, or happen to them post-death, so that their loved ones are supported. And it really is making this a health model issue that everybody can be comfortable with and discuss throughout life. Because there's so much to think about, and that's the message that we really want to get across to our people, because there's so many things to think about, and it's not all about care. So care is important, what your care preferences are, they are important, but equally for a lot of people, what happens to their pet cats if they die would be the most important thing to them. Or what happens to the watch that their grandma gave them, what would happen to that? And it's finding out what's important to those individuals that will inspire them to start to think about, talk about, and take action. So those that was clip on the screen there, you know, any Wizard of Oz fans in the audience will know that when Dorothy donned her ruby slippers, she cut her heels 3 times and made a wish that she wants to go home. In terms of our empowerment of our communities, that's what we're wanting to help people to do, is to, when they want to, when they're ready to enable them to get their own pair of ruby slippers, put those on, and throughout the life course talk about and take action in relation to their wishes for the rest of life and death. And this also helps them to improve their health and well-being to live an age group dialogue. Because people have the power to do this, and it's helping them to recognise those skills. Have I got any time left, Julia, to try and show another clip? 2 minutes? 2 minutes. That's okay then. So, let's hope this technology works this time. I'm going to try and end my presentation with a short clip, which will just give you a bit of an essence of some of the work we've done with our community members, where they, in their own words, explain some of the value of being part of some of our projects.
Very little to hear other people's views on how they have to subject to blockchain of people who really, in the first instance, have some resistance to it. But once you get under the surface, then you can often talk to them on the subject.
Listening to other people and hearing their very different ideas, and also hearing the interests people are in and helping others to think about aging well and dying well.
It's been really interesting and making me think what I want to do for the end of life plans. Because I've got absolutely no family to help support me, to rally around and be there with me. So it very much depends on my friends trying to double guess what I want. And I'd rather saving that burden while I've got a sense of humour and I'm well and fit, and concentrate on what I want, and have some peace of mind. I can then get back to the back of my mind and think, well, I've made my plans, exactly what to do. And today it's really made me focus on that, and I can look forward to doing it with a sense of humour.
Listening with a mix of people with all different skills and abilities, and people who are proactive and want to do things for them. I think it's a really good initiative, and I feel really proud to be here.
Living well and aging well, reading well and dying well, aren't just health and social care issues. They are public health issues that we all need to work together to address. So the partnership includes members from local voluntary organisations, from local community groups, from health organisations, from local authority, from police and fire, from local businesses, from housing providers, local churches, faith groups. Basically, anybody and everyone can be part of the partnership, because we can all champion and help to support ourselves and our loved ones and our communities to live, age, grieve, and die better.
Thank you.
Thank you.
Yeah, anyone has any questions for Rachel?
just wondered what approach you're taking to try and evidence some of the impact of your work, I suppose particularly around attitudes and behaviours.
Yeah, good question. Well, as I said, within the organisation now we have a dedicated research and evaluation department, and so what we're looking at doing is getting consistent evaluation across all the work we do. And so part of this is monitoring pre-knowledge, skills and attitude and post-knowledge, skills and attitude with every intervention that we do. So whether that's a one-off community session or whether that's a longer project. So that's something that we've just started to roll out in the past couple of months. And so hopefully within the next 6 to 8 months we'll start to have early indicators of that. But in the first 3 years of the programme, we commissioned Teesside University to do a study and evaluation on the roles of champions and the impacts upon them. And we also have a PhD student, Catherine, who's in the room at the back, who was aligned to the project for the programme for the first 3 years and has done some work on the attitude and behaviour change of members within our first pilot community sessions, which will be available shortly. As a poster as well, apparently. Yes, there is. Yeah, you might not have heard that what Catherine's saying there is that from the results at the moment, over 60% of people at 3 months follow-up had made an action or a behaviour change as a result of the community session.
I'm all for, obviously, working across with advanced care planning and getting people. I think that's a really good message. We're just struggling at the moment about are we raising people's expectations, because our commissioners have put a cap on what support people can have at home. Just 3 visits a day, and if it's more than that, then they have to go to a nursing home. And so there's a almost like an ethical question about, yes, we know that 70% of people want to stay at home supported by loved ones, but in reality, our commission is going to provide that. And what happens when there is that tension? And how do you sort of bring those sorts of commissioning realities into the conversation?
I think the key thing to recognise there is that this isn't just about advanced care planning. That's one of the small factors, but it is making people realistic to realise what the services are available in the local area, what's a possibility, what's not a possibility. I think the important part is to get people to be talking about that realisation that we are going to get older, we are going to die, and to be speaking and thinking about with their loved ones what they want. So that whole really gamut of choices that can be made, but with realistic expectations.
One last question here.
But you mentioned champions. Could you just describe a little bit what they do and what training they do?
Yeah.
And who they are?
We're actually, our current position is that we're developing a champions framework. So for the first 3.5 years of the programme, anybody who has had involvement with the partnership, and that's anybody who feels they have something to offer or wants to support us, we've named as a champion. And they have been able to access any of the training courses or community sessions that are run by the team to help to develop their skills, knowledge, and to empower themselves as individuals. But what we've actually recognised is that there's different activity levels within the members of the partnership. So some people who will like to kind of stay on the periphery, some people who will actively be ambassadors and be wanting to deliver for us and to create their own initiatives. And so we're just currently in the position of, with our champions, developing a champions framework that they are all happy with, that will have the right amount of training, and will be able to communicate our expectations of a champion and their expectations of us. So that's a piece of work that we're currently doing. But at the moment, we call a champion anybody who's involved in the partnership, but that will change to partnership reps and champions in the future.
Thank you, Rachel.
So just to remind you that you've got the break now. If you're interested in the 5th International Conference discussions, it's at 4 o'clock and 4:30 Singapore. 4 o'clock back in.